and my friends. So the topic for today is malaria elimination in Odisha, a way forward. A bit about background when we see about the malaria prevalence in Odisha and the prevalence in our country. At a stage, the malaria was posing a problem in 8 states, 147 districts with a population of 127 million, and out of them, Odisha and the northeastern states and some parts of MP, the prevalence was more, so a different strategy or a program was considered for malaria elimination. And the Global Fund is supporting this malaria program, and the intensified malaria control project which we will be discussing, and the basic focus what we have done in Odisha and what are the steps which we have covered. So for 7 northeastern states like Arunachal Pradesh, Assam, Manipur, Meghalaya, Mizoram, Nagaland, Tripura and Odisha. So this intensified malaria elimination program was for 39 months starting from January 2018 to March 2017. So the target beneficiaries were the marginalized groups, basically tribal population, women and children, and other key population like Jhum cultivators, forest workers, migrants, and the mobile population, especially in the border areas of states. And the project area, as we have discussed, the 7 northeastern states and Odisha. So the goal was to reduce malaria-related morbidity and mortality by at least 70% in the project areas by 2020. So with an objective of covering universal coverage of the population at risk of malaria with an appropriate LLI, that is vector control intervention, and achieving an universal coverage of case detection and treatment services at all levels in project areas to ensure 100% parasitological diagnosis of all suspected malaria cases and complete treatment of all confirmed cases. And without surveillance, any program doesn't succeed. So to strengthen the surveillance, to detect, notify and investigate and classify and respond to all cases and foci in these districts to move towards malaria elimination. And the thrust of the program, which we will know about what was the main intervention, local intervention or the state intervention which was taken, that is appropriate BCC activities to improve knowledge, awareness and responsive behavior. So the strategies and activities of this intensified malaria elimination was early diagnosis and complete treatment, human resource and capacity building like various trainings and various manpower trainings, vector control including LLIs which Global Fund had given into different months of the year, the Fund 1 and Fund 2. With that, health information system and monitoring and evaluation, program management including infrastructure and other equipments like the RDT kits, the LLIs, and improved diagnosis and treatment, coordination and partnership development. So these were the strategies. And coming basically now to Odisha, what we have done, you can see this bar graph showing this malaria over the years 2008 to 18, the key interventions which is influencing the trend. You can see the statistics like ABR and API, how it has come down over the years from 2008 to 2017. And the number of deaths and the case fatality rate. So the graph which comes down at 2017, you can see the all interventions. What were the interventions taken? So the new inputs were involving of ASHA in diagnosis and treatment. Involving of ASHA in diagnosis and treatment and RDT. And in the first phase we got 11.99 lakh LLIs. And next came the bivalent RDT and the second phase of LLI. And in the 2012 we had saturation of bivalent RDT and the second phase of LLI we got. And here we can see the inputs, and by 2017 it started both early diagnosis and complete treatment, LLI, and the focused program of Daman. So the current trend of malaria, if we see, there was the global support or the global fund which was supporting. It gave in two interventions, intervention 1 and intervention 2. So intervention 1 was basically global funding support, in which we got 11.34 million LI distributed in 17 most high burden districts, protecting around 2 crore high risk population. And the intervention period was April to July 2017. And the intervention 2 phase was basically a state support, where we got large scale mass screening activity was conducted in the months of August to November. That was the intervention period. So the focused intervention was these number of ASHAs, 47,174 ASHAs were working as FTDs or fever treatment depot holders and providing services for early diagnosis and complete treatment of malaria at community level. Alternative service providers were engaged for malaria diagnosis and treatment, and special surveillance and mass screening was done in inaccessible areas, individually, irrespective of fever status, because fever was one of the symptoms. Irrespective of the fever status, the mass screening was done for state-specific Daman program. And the improved diagnosis and treatment services, you can see now this pie chart shows that the passive surveillance from 2012 to 2017, if you see, increased from 61% to 81% in 2017, and 78% of the total diagnosis is done by RDT. So all the ASHA is to do that RDT at the village level. Long-lasting insecticidal nets, that is LLI, was the main thing which improved this program, and the focused intervention to distribute each and every house with an LLI was supported by global funding in 2 phases. In 2017, there was 1.3 crore LLI distributed, and this distribution again was also a problem, that how to distribute at the people or the community level. So this distribution through community mobilization approach was involving using GKS and CBOs to protect the most eligible population, and there was a steering committee at all state level, district level, block level, to involving all sectors, that how every members and from political platforms will have a transparent distribution and follow-up of monitoring of LLI distribution and the use rate. And so many innovative social mobilization and DCC campaigns were done, like the Nidhi Mosa to Mosarine, and for scaling up of this LLI usage, and most of the DCC activities were in regional languages in the districts, so that people can take up these messages and focused on malaria, anti-malarial activities. The intensive and innovative IEC was developed in different areas, like in Koraput and Malkangiri, we had some different like languages in Santal and Kuit tribes. Also the languages, the IEC material was also taken up. Wide dissemination of LLI messages through various platforms. The state malaria observance day, which was celebrated earlier, but now, in this period, the state specific extensive IEC drive was conducted in 30 districts. And sensitizing community by informant activities and traditional drum beating and unique bell ringing method, and interpersonal communication by making house-to-house visit by ASHA and health workers. And a 3-tiered approach was made on LLI use and maintenance, that is pre-distribution survey, during distribution, and post-distribution of LLI. So this was the main thrust of the program, like Daman, which we are telling, Durgam Anchalara Malaria Nirakarana, which was a state specific. The name as we signify in Odia, and this is a state specific project which was appreciated by at the national level also. So this Daman was unreached, and this Daman was focused on inaccessible areas for mass screening and population for malaria, and screening of vulnerable population for both nutritional parameters also. So it was implemented 3 rounds a year in 23 districts of Odisha to address this malaria and malnutrition. So the first round health camp was conducted in April and May, second round in September to October, and the third round was from Jan to Feb. So all these malaria screening plus health checkup of less than 5-year children plus pregnancy and lactating mothers, and all supportive activities like training, IEC, DCC, and intersectoral coordination and establishment of the non-ASHA activities also were established. So the outcomes, we had significant outcomes, and the follow which we did was a drastic positive thing which came out in malaria, that is the declining of cases. Community residing in remote and inaccessible pocket also got improved access to services. Population having asymptomatic, afebrile malaria were also identified and treated. Nutritional deficiency and low hemoglobin count were identified. And 63% decline in malaria positive cases was witnessed in Daman areas in 2018 compared to 2017. And decline of death also we have seen, and the test positivity rate in Daman areas have gone down to 2.93% from 6.28%. So with governance and support, any program, this was such a focused program that starting from the center, starting from the state, everybody was interested how to control this malaria. So the regular review of activity was at state level, the technical force and the interest by the administrative officers, and special attention for control of malaria, special budget from state government, special budgetary provision for procurement and supply of logistic chains, and review of district task force and malaria elimination was done. So this was all the governance and support which worked basically in this Daman program. And the successful impact of interventions, this also was shown in our Acharya sir's oration. You can see the graph. So from 2017, the decline of cases started. Overall, 82% decrease in malaria positive cases and 87% decrease in malaria deaths. So if you see the key achievements, Odisha is showing highest percentage of decrease of cases in the country in 2018, and compared to deaths and the state, PR is also 1.26 against this 6.56. So with current rate of reduction, the provisional API of Odisha is predicted to be 1.6 at all low time in the 4 decades. But some districts like Ragada is also still having, but things have been working out. So all you need is the plan, the roadmap, and the courage to press on to a destination, so that we will be succeeding as in the case of malaria. Thanks for listening.
It's live, sir. It's live.
Now, I would like to request Dr. Malini ma'am and Dr. H.P. Acharya sir to felicitate Dr. D. Shobha Malini ma'am.
Can I just take a few seconds, girls? Can I just take 2 seconds? Okay. Thank you, Shobha. You have nicely presented the things very exhaustively. Just 2 sentences I would like to tell to the audience over here. They are all public health specialists. Now, can you just think of, you are all specialists, how could we reach to, say, control or eliminate malaria? The thing I always tell to the students, and wherever I go, to the physicians over there, always give emphasis on EDCT, early diagnosis, and complete. It's not prompt treatment, it's complete treatment. And by complete treatment, I mean, please give emphasis on radical treatment. Because radical treatment, giving, say, primary, that is the only computer-sided drug, and that in fact brings the break in the chain of transmission. Okay? And second thing, we have achieved, but still our spring, Ragada is still having API more than the nearing 10. Why should there be some pockets where API is very high? So there is a school where 100% of 100 students appeared, 99 got first class and 1 child failed, and that is my child. So, no, it should be universal. Again, my original topic, inequality. So inequality should be bridged, and telling to the physicians or those who are giving EDCT in terms of the primary and radical treatment. Thank you so very much. Can you just add anything?